I'd like to welcome you and introduce myself. I'll be your host tonight. My name is Sam Capra, and welcome to the Hip and Knee Replacement Educational Seminar, coming to you from our Saint Alphonsus Baker City location. Just to introduce myself, I'm an orthopedic surgeon. I'm originally from the Bay Area of California. I attended college at University of California, Berkeley, where I majored in microbiology and physiology. I then attended medical school at University of California at Davis. And following that, I performed my internship and residency in orthopedics at the Carolinas Medical Center in Charlotte, North Carolina. Following that, I traveled to Canada, to London, Ontario, Canada, at the University of Western Ontario, where I underwent a fellowship training in sports medicine. I then went into practice on the North Shore of Lake Tahoe, and I was there for 15 years, doing primarily arthroscopic surgery, sports medicine, and trauma with all the skiers and snowboarders that would run into each other, run into trees, run into lift uprights, or occasionally they'd run into a BMW in the parking lot, but that's the story for another day. You're wondering how I ended up here after 15 years at Lake Tahoe and then 15 years on the Gulf Coast at Fort Walton Beach and Destin. My kids finished college down at Florida State, and they both ended up moving back out west, one to Portland, one to Reno, and I found Baker City, which was a good less than one day drive to see both of them. And you also have a wonderful little ski resort here, as well as bird hunting, and it all worked out. So tonight we're going to talk about hip and knee arthritis, and the topics we're going to cover are the basic anatomy of both the hip and the knee, the causes of hip and knee pain. That can be arthritis from inside the joint, or it can be problems from outside the joint, such as bursitis. We're going to talk about the non-operative management of arthritis, and we'll finally talk about the surgical treatment. Who's a good candidate? What can you expect? What kind of outcomes do we typically see? So let's start with the hip here on the left of your screen. You see the ball and socket. The knee on the right of the screen is more like a hinge or gliding joint. You see the ball is covered with this stuff called articular cartilage. It's like smooth, shiny, glistening stuff. When you eat a drumstick from a chicken, you get down to that end of the drumstick, that's the same stuff. It's a gliding surface. It's nice and smooth and pristine. The same thing at the knee. You have the end of the thigh bone and the top of the shin bone covered with this stuff called articular cartilage. And there's two categories of problems we face both with the hip and the knee. With problems from outside of the joint that can cause pain around the joint, and then problems from inside of the joint. Sorry, I keep reversing there. I'm just getting used to this. So in the hip, you have trochanteric bursitis, which typically is along the outer side of the leg. You feel that a lot of times with sleeping on too firm a mattress, or if you've taken a long car ride and the bucket seat is pushing up against the side of your leg, or sometimes with a long airplane ride when your wallet kind of pushes up against you. That's a very, very common cause of pain about the hip. You can also have pain coming down from your spine. What we call sciatica, or a pinched nerve, can radiate down to the side of the hip, and that may also radiate all the way down the leg. At the knee, you have a thing called iliotibial band syndrome, which is on the outer side of the knee, where you can get inflamed tendon tissue where it rubs against the side of the knee. You can get what we call patellofemoral pain syndrome, which is basically when the front of the knee hurts and it's coming from your kneecap. And a lot of time it's from sitting too long and then going to stand up. So looking first at the hip, we have trochanteric bursitis is the fancy name for it. You see the greater trochanter is a bony projection, and that's an attachment point where a bunch of your muscles attach. The gluteus maximus, the gluteus medius attached there. But that can get irritated, and you can see there's another muscle that runs outside of all that. It actually stops at the top, starts at the top of your pelvis, runs all the way to the knee, and it runs past that bony projection. And we have a thing called a bursa sitting in between the bone and that muscle. The bursa is like a little anti-friction device, and it's kind of like a little sack with one drop of super slick fluid in it. And the idea is it lets the muscle glide by the bone. But sometimes that bursa gets inflamed. Like I said, it'll often get inflamed with a long car ride, a long plane flight, those types of things. The symptoms are classically lateral or outside of the hip pain, on the outer side of the hip, particularly if you sleep on that side, or if you sit too long and go to stand up, it can be quite uncomfortable until you get walking for a little while. The treatment for it typically is either anti-inflammatory, such as Aleve or ibuprofen or Advil, or maybe physical therapy and stretching exercises, sometimes even cortisone injections. A lot of the treatment's just figuring out where it came from. If your mattress is too firm, a lot of times I see patients that just got a new mattress and it's hurting them. I suggest that they put a mattress pad, a second mattress pad underneath the sheet, or get a small pillow top or even an egg crate in order to soften the mattress a little bit. Then things like stretching exercises can help quite a bit as well. If you're taking a long cross-country car trip, you might want to stop at AutoZone and get a little cushion to sit on so that your bucket seat isn't pushing right against the side of your hip as well. Of course, when it comes to airline flights, I would say fly first class, but I can't do that either, so we'll just move on from that idea. Sciatica is where the nerve in the lower back is being pinched by either a spur from one of the facet joints or from a piece of the disc pushing out and pushing on the nerve, and that can radiate and give you pain on the outer side of the thigh. Most of the time, though, with sciatica, the pain will run down the back of the leg, and it may run all the way down to your foot, and you may get numbness, tingling, pins and needles feeling. The treatment for that can be multiple things. It may start with anti-inflammatory medicines like ibuprofen. It may go on to steroid medicines like prednisone. It may involve formal physical therapy. It may involve injections into your spine and even referral to a spine specialist for surgery to decompress the nerve. So down at the knee, on the outer side of the knee, as you see in this picture, we have a thing called iliotibial band syndrome, and that's when this long muscle and tendon is kind of rubbing against the side of the knee and against the bone. And that's usually can be from something like running or just a particular activity that you start and you haven't done in a while without adequately stretching. And the treatments for that are going to be physical therapy to stretch that muscle out, again, anti-inflammatories, and occasionally cortisone shot. But with none of these things is surgery likely unless it's a really bad sciatica in the back. Now, patellofemoral pain syndrome, this is an MRI, and you're seeing at the top of the MRI, you see the kneecap. And those nice arrows are showing us how there's nice space between the kneecap and the thigh bone. And you see on the right-hand picture how the kneecap's kind of tilted over, and that causes increased pressure and causes the kneecap to hurt. And typically people talk about pain at the front of their knee. We have a sign in orthopedics called the movie theater sign. That's when you sit at the movie theater with your knees bent for 2 hours, then you go to stand up and you get sharp pain in the front of the knee because that kneecap has been overpressured while it's been bent. So again, anterior knee pain, prolonged sitting, stair climbing, or particularly stair descending or hiking downhill are reasons people complain about this. So this can be from quadricep muscle weakness, causing the kneecap to not quite glide correctly the way it should at the end of the thigh bone. And typically, treatment for it's going to be physical therapy to strengthen the muscle and to correct the alignment of the kneecap. Can also involve anti-inflammatories and occasionally even injections. Now, when we get to causes of pain inside the joint, that's what we're really talking about here tonight. We're talking about arthritis. And if you look at this knee, you see on the left a normal looking knee with nice gliding surface. And you look on the right and you see the gliding surface is worn away. So now we're getting bone rubbing against bone. We're getting narrowing of the space between the bones, and that's what causes pain. Now, if you look at this X-ray, you see on the left normal joint space, and you see on the right an arthritic knee where the joint space is gone because the gliding surfaces have been eroded away. This is the picture you see a lot when you're in an airplane and you read the in-flight magazine, and there's always an ad for some clinic, and they show the bad picture on the right, and then they show the good picture on the left, and they tell you that if you come to their clinic, they're going to inject you with a magic potion that's going to restore a normal knee. That's all snake oil. Don't believe a word of it. You cannot go from the arthritic picture back to the normal picture. So be very dubious of any of those claims. Now in the hip, again, remember we have that nice gliding surface that covers the end of the bone and it lines the socket. On the right-hand side, you see a picture where all that gliding surface is worn away and it's left us with a narrowed joint space, and now we're getting pain from bone rubbing it onto bone. Here's an x-ray showing the same thing. You can see the normal joint space on that left picture, and on the right you see there's no joint space at all. That's a very, very arthritic, painful hip, and that's a great candidate for a hip replacement surgery right there. So in the hip, you're going to have activity-related pain with arthritis. A lot of times it's in the groin. People tend to think hip pain is going to be back in their butt, but mostly the time it's in the groin. People think they had a groin pull. It can radiate into the buttock. It can radiate down to the knee. I've actually had patients that showed up with knee pain, and it turned out to be their hip joint because they do share some of the same nerve supply. Some of the symptoms people complain of is difficulty getting their shoes and socks on because they can't bend their leg well enough, so they've lost range of motion. And they find that they're limping. They sometimes feel like that leg is shorter than the other one. Some of the things that really bother them are sitting for a while and then going to stand up, and you get sharp groin pain. That's called startup pain. It's kind of a classic presentation. But it's activity-related pain. The more you're on it, the more you walk on it, the more it bothers you. Now in the knee, you also get activity-related pain. Again, you've got this worn-out joint. The more you're on it, the more it hurts. You're going to get stiffness, limping. You may get swelling. You may get loss of range of motion, inability to fully straighten or fully bend the knee. And you may notice deformities. You may start getting bow-legged, or you may start getting a little bit knock-kneed. When we talk about knee deformity, you can see that green line shows a normal, what we call mechanical axis. If you draw a line directly from the middle of the hip joint to the middle of the ankle joint, it should go right through the middle of the knee joint. When you have a knock knee, or what they call a valgus knee, you notice that that line is going outside of the knee, and that knee is going to wear out on the outside portion, preferentially because that's where it's taking most of the stress. When you get a bow leg, you can see that that joint force is going to go to the inside of the knee, and that person's going to wear out the inner side of their knee, most likely first. So non-operative treatment of arthritis, what can we do without surgery? Typically the treatments are, let's talk about first activity. What's good activity and bad activity? Well, good activity is low impact activity. Think stationary bicycle, elliptical trainer, swimming, aquasize. Think outdoor bicycling, cross-country skiing. Those are all good activities that don't impact the knee. They don't cause a high impact force. Jogging, jazzercise classes, those are the kind of things you want to avoid. Weight loss. Weight loss can help. Even a small amount of weight loss takes that much weight off of the knee, and you think about every step you take, there's a little bit less weight on it, and that adds up over time. Bracing probably has gone out of favor. There was a theory for a while that you could wear these braces that would unload the one side of the knee or the other, and further mechanical studies have shown that doesn't really work. But sometimes just one of those little knee sleeves, like a copper fit sleeve, it can keep your knee a little bit warmer and make it feel a little bit better. So I'm a big fan of those, but not the big expensive derotational or unloader braces that likely don't work. Gait aids, what do we mean by that? Well, a cane. Using a cane or even using a walker can help. Therapy can help restore range of motion and therefore can help decrease pain. And then we get into injection therapies, and there's typically two injection therapies that work. One is cortisone injections, and that's kind of our go-to. The cortisone injection basically is an anti-inflammatory we put in the knee joint, and it brings down swelling, it relieves pain. and it's typically going to do that. The question is, how long will it last? The answer is, we don't know. I have lots of patients, they come in and get a cortisone shot, they're good for 6 months or a year, and then they come in and we'll do another one. And we'll do them until the cows come home or until they stop working. Some patients get cortisone shots, they don't last very long at all, maybe weeks or even a month or two is all. And then we have another kind of injection, it's a backup injection, and this is purely a lubricant. There's several brands, Orthovisc, Hyalgan, Synvisc, Suparts, Euflexa, and essentially they're all kind of a grease. And what we're doing with those injections is just sticking a grease into the knee joint between those worn out bones. It's kind of like doing a lube job on your car. If it works and it lasts a good 5 or 6 months, you can repeat it every 6 months. The problem with those injections is they're not that predictable. They work about 60% of the time, which isn't that much higher than a placebo effect. Some insurers will cover them, some insurers will not cover them. Now there's some other types of injections you may have heard of. There's one called PRP, which stands for platelet-rich plasma. There's been lots of claims that that does incredible things and restores gliding surface. Actually, there's no double-blind prospective scientific evidence that shows that it does anything, which is why you'll find that your insurance company will not pay for it. Typically, when a clinic offers that, you need to be aware that you're going to get socked with a bill and you're going to have to pull out your credit card for it. The other big injection therapy that you read a lot about is stem cell injection. And somehow the idea that you're going to take these stem cells and inject them into an arthritic knee and the knee is going to become a 20-year-old knee again, unfortunately is a fallacy. And once again, double-blind randomized prospective scientific studies show absolutely no effect from the stem cell injections. So beware, if you're in a clinic where they want to inject stem cells, I hope you brought your credit card and I hope you've got a lot of credit on it because they're going to run up a big bill. Your insurance will not cover that. So, non-operative treatment, activity restriction, weight-bearing activity, low impact activity is good for joints, but not high impact activity. Okay, again, cash pay injections and treatments, that would be the stem cells, that would be the platelet-rich plasma, that would be the ads in the in-flight magazine. Be very suspicious of those. If they say you've got to pay cash for them, it means your insurance company won't cover them. Insurance companies, bless their hearts, and I know from living in the South that once you say bless their heart, you can say whatever you want about somebody. Insurance companies, bless their hearts, actually know what they're doing when they look at treatments and see whether they work or not. And if they're not going to pay for a treatment, that should tell you it probably doesn't have results that suggest that it works. Now, we get to treatment with arthroplasty. That's surgical treatment. Okay, what is the goal of surgical treatment? The goal is to relieve pain and get you back to activities of daily living. How does that work? Well, it works by taking out those worn out bone ends and replacing them with metal and plastic. So instead of having bone rubbing on bone and causing pain, you have metal rubbing on plastic with no pain. So in the hip, this is a picture of essentially what a hip replacement looks like. We go into the body, we remove your native ball, we deepen the socket, and put in a titanium socket into the pelvis. There's a plastic liner that snaps into that socket. Then in the top of the thigh bone, we put this stem in. It's also made of titanium, and either metal or ceramic head snaps onto that, snaps into the plastic liner, and the bone grows directly into these titanium components, the stem and the socket. We rarely cement hip replacements anymore. This seems to work very, very well. And here's a cool little video showing exactly how long it takes to do one of these. About, I don't know, 15 seconds. There we are. So in real life, it takes like about an hour and a half to do that same thing, but it's kind of a cool video. Here's an x-ray before and after. Again, on the left, you see the x-ray, you see no joint space between the top of the ball and the socket. That's a pretty worn out hip. And then afterwards, we put the hip replacement in. So there's no bone touching bone, and that's going to relieve the pain. So in a knee replacement, you have the worn out bone. We cut the bone ends off. We cap the thigh bone or femur with a metal component. And then on the tibia side or shin bone side, we have a metal component. And then in between, we have this plastic spacer. Now, typically in the knee, we will still cement these metal components in, although we're experimenting more and more with cementless components, and they're being tried and have some good short-term results. Back when I was a resident 30 years ago, we tried the same thing and it didn't work so well. So we'll wait and see on that one. So this is what it looks like beforehand and then after. Now you notice the ligaments on the sides of the knee are still there. So basically make an incision, we remove the bone ends, but leave these ligaments so your knee is still stable from your own native tissue. So who's going to benefit for a hip replacement or a knee replacement? Well, let's look at this list here. First thing it says, patients with moderate to severe arthritis on x-ray. True, but it still comes down to whether it hurts or not. And I'm going to give you an example. Several years ago, I had a patient come in for a second opinion. I looked at his x-rays. He had pretty bad arthritis of his knee. And he told me that he'd been told by another doctor that he should go ahead and have a knee replacement done while he was young and healthy. And I asked him, how much does your knee hurt you? And he thought about it and he said, well, you know, doc, last month my son and I hiked across the Grand Canyon. And you know, by the end of the second week, I had to take an ibuprofen one night at the campfire. I told him he should go back to hiking and take an ibuprofen when he needs it and not get a knee replacement. So it's not about your x-ray, it's about you. How much is the pain limiting your activity of daily living? Activity of daily living is the key. If you've failed non-operative treatment for at least 3 months, and that would include anti-inflammatories such as ibuprofen, that might include cortisone shots, that might even include those lubricant injections like Hyalgan. If none of those have worked and you're continuing to have significant pain with activities of daily living, then you're a candidate. Now, these are not going to return you to being a jogger or a runner. They're going to allow you to be able to walk comfortably to the store. They're going to allow you to buy groceries. You'll be able to swim, bicycle, hike, but you're not going to be running or jogging. Before the surgery, we want to optimize your modifiable risk factors, and that's a fancy way of saying you'll probably have to lose weight. If you have type 2 diabetes, your hemoglobin A1C, and those of you out there know what I'm talking about, your hemoglobin A1C wants to be under 8, even better if it's under 7.5. If you're a smoker, smoking is the leading modifiable risk factor for infection. So if at all possible, we got to get you off the tobacco. And then your size. The BMI, you've heard of, body mass index. It's a rough estimate of how big you are or how overweight you are. A BMI over 40 is pretty much a reason to not undergo this surgery. And you've got to remember, this is considered an elective surgery. So if you have a high BMI, you are at significant risk when you undergo one of these surgeries. You're at a significant risk to have an infection. You're at a significant risk to have other complications such as problems with anesthesia. You're at significant risk to develop blood clots and have a clot break off and go to your lungs, a thing called a pulmonary embolus. So given all those risks, we found that the risk to benefit ratio is too low in larger patients, and their best bet is weight loss first, the joint replacement second. The weight loss may be able to be done through a program, you know, an eating program with your primary care physician. Sometimes we even end up referring patients for a bariatric surgery, which is a fancy way of saying stomach stapling or gastric bypass surgery to lose weight before doing a joint replacement. So who should not get a hip or a knee replacement? Well, again, minor or occasional symptoms. I'm going to go back to that gentleman who told me he was hiking across the Grand Canyon. He did not need a knee replacement. Patient with mild x-ray findings of osteoarthritis, that can be a little tricky because you may have mild arthritis on x-ray and it just won't get better, and we do an MRI and we discover there's a lot more arthritis than the x-ray showed. So that's sort of a relative indication. Patients that expect to return to high impact activity or high level sport, that's not going to work. No high impact activities because these things wear out. My best example there is Bo Jackson. I actually got to, when I was growing up in Oakland, I got to see Bo play when he was playing for the Kansas City Royals, and he was an astonishing athlete. He played football for the Oakland Raiders. He played baseball for the Kansas City Royals. He suffered a hip dislocation while carrying the ball in a Raiders game. Well, what happened was his hip developed a thing called avascular necrosis. He lost the blood supply and the ball of the hip joint collapsed. Bo went and got a hip replacement. And this is a 32-year-old athlete getting a hip replacement. He went back and he told the Kansas City Royals that he was ready to play baseball again. They went to their orthopedic team, and their orthopedic team for the Royals said, what do you think? Bo wants a new 5-year contract at X million a year. He says he can play. And the orthopedist said, no. And the Royals listened to that and they cut him. He signed on with the Chicago White Sox, played half of one season for the White Sox and broke his hip replacement. He then got to undergo, at age 32 and a half, he got to undergo a revision hip surgery. So Bo spends a lot of time with archery and golf now, but you don't see him doing any more high impact activity. Patients under the age of 50 should exercise caution. Well, what does that mean? That means that these things have a finite lifespan. We expect hip replacements with moderate use to last up to 30 years. We expect knee replacements with moderate use to last up to 20 years. So if you're under 50, you're going to wear one of these things out. Having said that, there's people in their 40s that end up getting joint replacements. I've done them. I had identical twins that had both had bad knees at age, I think they were 42. And that's genetic. Their gliding surface cartilage or articular cartilage genetically was poor, and they'd inherited that from everybody in their family had joint replacements when they're in their 40s. And if their activities of daily living are that limited, you go ahead and do the joint replacement, but with the understanding that in their 60s they may be getting another surgery, and in their 80s they might have to have a third surgery. That's not optimal because each surgery is harder with more complications and higher blood loss, but sometimes it has to be done. So recovery, how long does it take to recover from one of these surgeries? Well, our goal is to get you weight bearing immediately after surgery, get you up the same day and start walking you up and down the hallway. Okay. You'll use a walking aid, typically a walker, for the first several weeks. You'll be doing a lot of working out with a physical therapist. Now, this slide says 80% of the patients go home the same day. Not really accurate. This slide referred to an outpatient center in Boise where people are pushed to go home the same day. Typically in Baker City, you're going to come in, have your surgery, stay overnight, get another therapy session the next morning with a goal of getting you out, say within 24 hours, getting you back home, where the home physical therapist will come to your house and work with you for the next 3 or 4 weeks. The home nurse will come and visit and change your bandage and take your stitches out. That way you don't have to get in and out of the car or travel anywhere for the first 4 weeks after surgery. People do better when they go home after surgery. We've compared the rates of people having problems when they go home and recover at home versus people that go to, say, a nursing center or nursing home for an extended stay before going home. The people that get home do better. I'm not sure if that's because they sleep better or they're in a familiar place, but they do better and they recover faster. At the bottom there, you notice it says improvements in pain and function continue for 2 years after surgery. There's a question with expectations. I have patients that think within 3 or 4 weeks after a knee replacement, they're supposed to be full tilt, no pain, and walking 10 miles a day. That's not real. It's typically about 3 months after a knee replacement before you start to feel back to being your normal self. It's probably 6 to 8 weeks after a hip replacement before you start to feel like your normal self. They're big surgeries and they take a while to get better. And again, you can get better for up to 2 years afterwards. So recovery from a hip replacement may have some specific range of motion precautions. Your physical therapist would teach you all those. It involves not sitting in low chairs or sitting on a futon. You may end up with an elevated commode or bathroom seat so you don't go down too low initially in the first several weeks after surgery. Hip replacements, though, do great. They typically feel a lot better than they did before surgery within 2 to 6 weeks. I've seen patients literally same afternoon after surgery walking in the hallway and saying that their pain is gone. They already feel way better than they did beforehand. Hip replacements do really well, much shorter term pain. Knees, not so much. Typically, a knee replacement patient comes in the office 2 weeks out and they're looking at you and you can tell they're thinking, what have you done to me? So the knee replacements take longer. It's going to be 6 to 12 weeks or they're in some pain and they're dealing with swelling, they're dealing with physical therapy, they're waking up every morning thinking, I got to do 100 leg lifts, I got to do 100 knee bends. Don't expect to want to go on like your planned retirement cruise within 3 months after a knee replacement. Give yourself a good 3 months, and it's probably 6 months before your brain forgets that you had one of these things done. Okay, let's talk about things that can go wrong, because anytime you talk surgery, you got to talk about things that go wrong. And by the way, I want to say right here that if you ever have a surgeon who tells you that they never have complications and nothing ever goes wrong for them, you should probably walk out of that office and find an honest surgeon, because we all have infections, we all have complications, we all have post-operative falls that cause fractures. I don't know anybody in my profession hasn't had a patient have a blood clot or maybe a pulmonary embolus or a stiff knee or incomplete pain relief. These things happen, they happen to all of us. If you have somebody tell you that none of that stuff ever happens to them, walk out on them. What can happen? Hips can dislocate, typically 1% or less of the time. A single dislocation, we usually reduce it. We treat it conservatively by limiting motion and then going through physical therapy and expect that it will scar in and heal. If a hip dislocates multiple times, that means there's a problem with the alignment, and that likely will lead to a revision surgery. Knees can be stiff. Occasionally we do a thing called a manipulation under anesthesia if the patient's not developing the right amount of knee motion that we want to see by 8 to 12 weeks after surgery. That's probably less than 5%, I guess 1 or 2% of the time. Incomplete pain relief, honestly, there's about 2% of people that we just never know why. We get good results in 94 to 96% of joint replacements, but there's 2 to 4% where either they have a complication or they still have pain, and a lot of times we really don't know why. Sometimes they end up in the pain management, getting injections or nerve blocks as well. Blood clots we try to prevent by having you on an aspirin regimen for a month after the surgery to keep your blood a little bit thin. Component wear and loosening is usually seen less and less because these things are getting better and better. The engineering of them is better and better, but it can happen probably 1% or less of the time. Fracture, if you have a fall and you have a fracture or a break around one of these things, that can be a significant surgery to put the pieces back together. Sometimes you'll have to have a whole new joint replacement put in with a longer stem that bypasses the fracture. And those type of surgeries are usually done at a revision center, such as the Saint Alphonsus Trauma Center down in Boise. So how long do these things last? Well, they used to wear out pretty quickly. Now they don't, because we have better materials. The hips, 30 years or more. The knees, 20 years or more, unless you're Bo Jackson. Hot topics. You've heard about all these. You read about these in the ARP magazine, things like that. Robotics. That's a Stryker Mako robot there. I'm trained in that. I used that the last place I worked in Florida Panhandle. They're fun to use. They work well. It looks like, if you could look in the operating room while we're using one, it looks more like the Toyota assembly line than it does an operating room. The reality is computer-assisted surgery and robotics, may or may not be better. There's actually no hard evidence yet that there's any improvement versus doing it the standard way with mechanical guidance and fixation. So it's still a 6 of one, half dozen of the other. Minimally invasive approaches, those were popular for a while in the past. Those have kind of gone by the wayside because there was a much higher incidence, particularly in knee replacement, of stiffness, incomplete tissue releases, and problems and higher complication rates. Continuous passive motion machines, if any of you know, these machines that after a knee replacement you lie on your bed and put your leg up in the machine and the machine moves your leg back and forth and it feels really good. Unfortunately, at 6 months after surgery, there's no difference in function between patients who had them and patients who did not have them. So bless their hearts, the insurance companies won't pay for that because they know those statistics and there's no effect on your long-term recovery. Cryocuffs, wonderful things that you can put on and they connect to a little ice chest and they circulate cold water around the joint replacement. And they're kind of cool because you can also chill your beer at the same time as you chill your knee. Again, no long-term difference in recovery rate, so bless their hearts, the insurance won't pay for those either, but you can find them on Amazon if you want to use one. And they are great for chilling your beer. Bottom line, hip and knee arthroplasty, or hip replacement, knee replacement, they're very successful procedures. Over 500 to 600,000 hips replacements are done a year, over 500 or 600,000 knee replacements are done a year in the United States. It's a staggering number, and they, again, 94 to 96% good and excellent results. The differences between approaches is that an anterior approach or a posterior approach to the hip, turns out those are insignificant. Those have been studied. A lot of those things were based on marketing. The town I used to live in, one of the clinics had started doing an anterior approach. They actually had a big billboard touting the fact that they did their hip replacement with an anterior approach. Well, it turns out that there's no difference whatsoever between approaches and the results are the same. So beware marketing. Now, this is probably the most important part of this lecture tonight, this talk. What to look for in your surgeon? Well, first off, you want to meet your surgeon, and I'll get to that in a minute. Does your surgeon listen to you? Do they examine you? Do they ask you questions like, do you have stairs in your house? Do you have one-story living? Do you have somebody that will stay home with you? Do you have 8 cats? That's a significant problem. And they explain things in language that makes sense to you rather than talking in fancy orthopedic or Greek or Latin terms. Do they talk about, you know, your knee and your thigh bone and your shin bone? Do they help you make your decision rather than telling you what to do? So some surgeons will say, you need this done. A good surgeon will say, well, here's the options of care and here's the odds that each one's going to work for you. You decide when you're ready to have surgery because it's your decision. It is an elective surgery. It's your decision. Volume of surgeries. So if you want to have a revision knee or revision hip replacement or a second revision hip or knee, I'm going to recommend you have that done by someone like Dr. Jin down in Boise, who's specifically subspecialty trained in revision surgery. If you're having a straightforward knee replacement, you want a surgeon who's done a bunch of them and who feels comfortable doing them. It doesn't matter the exact numbers as much as it just matters, is your surgeon comfortable doing it? And you know what? Ask them. I'm always happy to answer that question. Ask them. Say, do you feel comfortable doing this or not? What happens if a complication occurs? Well, that's when the surgeon should be sitting by your bedside, holding your hand and talking to you about what we're going to do, how we're going to fix this problem, how we're going to address this problem. And it should be a problem that they mention to you before surgery. They should sit down with you before surgery and talk about, here's the things that might go wrong and here's what we're going to do if each of them occurs. So the things to watch for, and I'm going to start right off with that purple one on the right. Doesn't meet you until the day of surgery. And I'm trained as a surgeon but also a physician. Unfortunately, and this is sort of embarrassing to me, but in my profession, there are orthopedists who've set up clinics where you do not meet the orthopedic surgeon until surgery. You go to this clinic because everybody said, this is the guy, he does 5,000 of these a year, this is the guy you got to go to. You see a physician assistant. They talk to you, they schedule you. The morning of surgery, some guy you've never met walks in, holds his hand out and says, I'm Dr. Smith, I'm your surgeon. If everything goes well today, you'll never see me again. I know of this happening, I'm horrified by it, and that's not really what you want. You want the guy that warned you in advance that something might go wrong, and if something does go wrong, they're there walking you through it. So trust your instincts on that. If the doc is very short with you, doesn't spend time with you, you know, there's other orthopedists. You want somebody that you feel comfortable with. If they don't listen to you or don't stop to examine you, well, that's a problem too. If they push you into particular treatment, saying, especially if they push you into a treatment that's not covered by insurance. Remember stem cell injections and platelet-rich plasma injections? Those treatments are a cash cow for their clinic because you're going to pull out your credit card when you exit and have to run it off on your card. So be leery of those. Arrogance. If they claim to be the best, ask them how they know they're the best. If they claim they've never had a complication, run out of that office, because as I said earlier, they're not being truthful. And if they say they have game-changing technology, don't believe a word of that. We're all similarly trained. We all have to do continuing medical education, and we all go back and continue our training and learn the newest techniques. So beware of everything on that list. Now, it's not just the surgeon. It's the other people too. It's the office staff. It's the surgery center or the hospital inpatient staff. They all work together as a team to take care of you, because your surgeon can do a really good job in surgery, but he or she is only doing a really good job because they've got a great scrub tech, they've got a great circulating nurse, and they've got a great anesthetist. On the floor, you've got to have nurses that know what they're doing. We happen to have some really good ones here. So they're all in a partnership together. And I have to say, I've been here 6 months at Baker at the Saint Alphonsus Baker Medical Center, and I've been very impressed with the team I'm working with. I think we have a good quality team, and I will tell you this, if you decide to come here to have something done, we'll take good care of you. If you want more information on hip replacement or knee replacement, you can go to orthoinfo at aaos.org. That's the American Academy of Orthopedic Surgeons. One other thing, your orthopedic surgeon should be a member or what's called diplomate of the American Academy of Orthopedic Surgeons, as I am. So thank you very much for listening and for letting me prattle on. And at this point, if you've got questions, we have some kind of a chat line set up or some kind of setup that Juan is handling here. Yeah.
First off, I want to thank you, Dr. Capra, for presenting us with this very useful information for those who are interested in hip and joint options here moving forward. We want to go ahead and move over to our question and answer portion of our seminar. We're going to go ahead and start with some frequently asked questions, but we also want to encourage the folks who are still on the seminar here with us to ask any questions that you have on the chat section here of the meeting. And then we'll pick them up as I go through the questions that we have listed. So Dr. Capra, what kind of pre-op testing will I need, and do you need medical records from my primary care doctor?
So very good question, because typically when we're in the clinic and we start talking about making a decision to get a knee replacement or hip replacement, there's several steps that we have to go through. One is we have a joint replacement class that you have to attend. It's a video class, but it's an educational class to give you an idea of what you can expect before surgery, day of surgery, and following surgery during your recovery. You have to have a medical clearance from your primary care provider. They have to address, are you in shape for surgery? Can you handle anesthesia? So you have to undergo medical clearance, and as part of that medical clearance, there's going to be several lab tests. There's going to be typically what they call CBC, or complete blood count, a chemistry panel, a bleeding test called a ProTime. Usually we do a type and screen just to make sure if there's unusual blood loss and we had to have a transfusion, we would be ready to do that. We also test for what's called MRSA. They do a nasal swab to see if some people are carriers of MRSA, which is methicillin-resistant Staph aureus. And in that case, if you test positive, there's extra steps we take or extra antibiotic we add, sometimes nasal swabbing that we do preoperatively as well. We also, one other thing we'll typically do here is refer you to the physical therapy department for what we call a prehab session, where they go through a session educating you on some of the exercises you're going to be doing after surgery and your expectations for how long you might be using a walking aid and how soon you can get back to your regular lifestyle.
Awesome. Are there any foods, drinks, or activities I should avoid for my treatment?
You know, as far as the night before or the day of surgery, you'll get a list on what you can and can't do. No solid foods after midnight the night before. Typically, we have a cutoff time on any clear liquids, and we'll be real specific about that with you. As far as activities beforehand, we recommend you should be sleeping in clean sheets, clean pajamas. If you have pets in the house, that's something you need to deal with. You may want to make sure your pets are out of the bedroom or the room you're going to spend time in. You don't want the pets anywhere near your bandage or your wound. And ideally, if your pet can stay with a friend for a week or two, that's honestly what we recommend as the best thing. I did mention, I made a joke earlier about the 8 cats. I had a patient who had 9 cats, and he was not a surgical candidate because he had 9 cats and lived by himself with his cats. That was something he was going to have to address before getting a knee replacement.
Okay. Why do I have to go to the dentist before surgery? And will I need antibiotics before dental work?
That's a great question. So we do talk about your dental work, your dentition or lack of dentition. Infection in joint replacement is a catastrophic complication. In the worst case scenario, it could lead to an amputation. Getting some of the bacteria from, like if you've got a bad infection in your mouth, and if that were to spread in your bloodstream and lodge in one of these joint replacements after the surgery, could lead to really catastrophic effects. That's why we always ask you about your teeth. Have you seen your dentist? If you haven't seen your dentist in a while, we'll make you see your dentist before surgery. If you are scheduled for a root canal, we're postponing your elective surgery until the dentist says that your socket is completely clean and there's no infection in your mouth. Was your other questions about antibiotics? After you've had a joint replacement, we'll usually recommend antibiotic pre-dental appointment for up to 2 years afterwards. Not necessarily for cleaning, but for anything more than that. If you're diabetic, we usually just recommend lifetime, just to be on the safe side, because diabetics don't fight infection as well as the rest of us. And so we usually recommend antibiotic before any dental procedure, and the dentists are very aware of that.
I know we have a few folks that have their hand raised here on the Teams. We did disable the audio for everyone except for Dr. Capra here. If we could ask the questions on the right-hand side on the chat, please, we could definitely communicate that. Hopefully it's a question we can answer for you. Thank you. Dr. Capra, another question is, when can I drive? When can I travel?
Another great questions. Okay, so when can you drive? If assuming you don't drive a clutch, assuming you drive an automatic, and it's your left knee or left hip, basically as soon as you're comfortable getting in or out of the car. If it's your right knee or right hip, which is your driving leg, we recommend 4 weeks, because we've done studies and show it's about 4 weeks before you have the muscular reflex control back to be able to operate a motor vehicle.
Awesome. When can I swim or participate in other water activities?
Okay. For swimming, typically, or for just getting in a pool, I'm going to say typically about 4 weeks. Your incision has to be completely healed. Typically, stitches come out at about 10 days. And we put something called steri strips on, but we really don't want you getting in a pool or particularly a hot tub, which is just a cesspool of stuff, for about 4 weeks after the surgery.
Is there an age limit for knee surgeries?
No, ideally on the lower end, you'd like to be in your 50s. We did talk about that earlier, but occasionally we do someone in their 40s because they probably had genetically poor gliding surfaces and wore them out. As far as upper age limit, it's more a function of your activity level and your medical condition rather than your chronologic age. It's your, I guess I should say, your physiologic age rather than your chronologic age. We have done patients into their 90s that were active people and had a lot of pain.
Perfect. Dr. Capra, how often will I need follow-up visits after the procedure?
So our routine typically is you're going to have the home health physical therapist and home health nurse working with you for the first 4 weeks. We'll usually see you back in the office at about 4 weeks out and do a troubleshooting visit. Likely do some outpatient physical therapy after that if you're a knee replacement patient. Often hip replacement patients at 4 weeks are comfortable doing their own therapy from then on out. We usually see you back again at about 4 months after the surgery, do a check x-ray, and then usually about another year after that for kind of a final troubleshooting visit. And at that point, we give you a list of things to watch for. If there's certain problems arise, we would want you to come back in to have them rechecked.
Awesome. How often is it safe to get cortisone shots? Is there a gap? Is there a treatment period?
Yeah, that's as far as cortisone shots, and if you've got somebody who's otherwise healthy and they're getting a cortisone shot more than every, say, 4 months or so, that's probably too much. The problem with cortisone is in the short term it gives you good pain relief. In the longer term, it actually breaks down what's left of your gliding surface, can soften it, make it easier to wear out. So it's a sort of a two-edged sword. Now, if you've got a patient with other medical conditions that really isn't a surgical candidate, they may be stuck just with getting a cortisone shot every 3 months or so, and that's not an ideal situation. Now, if you're healthy enough and the cortisone's not working for you, surgery is really a better option for you for the long term.
We have a question from Kirsten. What is considered high impact exercise?
Jogging, running, jazzercise, anything like that. Singles tennis, real stop-start stuff, basketball, volleyball, court sports. What can you do? Let me tell you what you can do. After a knee replacement, the only real limitation I put on a knee replacement patient is I don't want them doing those high impact jogging, running sports. They can probably play doubles tennis. They can definitely ski. They can hike. They can swim. They can ride a bike. All those kinds of things are fine. Now for hip replacements, pretty similar answer, except that I did mention earlier that I was in practice at Lake Tahoe for 15 years. After 15 years there, I have to say, if you've had hip replacement, I'd be real leery about going back to skiing. And the reason is you're putting this like 5 foot long lever attached to your foot, attached to your boot, and if you twist wrong and fall wrong, you got this huge lever arm torquing your hip replacement, seeing if it can pop it out of socket or even worse, get a break around it. And I saw some really bad ones at Lake Tahoe, to where as a skier, I don't recommend downhill skiing after a hip replacement. I'm a killjoy, what can I say? Sorry.
Follow-up question, what about weightlifting?
Weightlifting's fine. Now, shoulder replacement and weightlifting, different story, but that really wasn't our topic today.
Looks like that does conclude some of our questions here. I did want to end it here on a simple question, but I think important. Should I apply heat or ice?
That's always a good one. Ideally, early on, the first several days after an injury or after surgery, ice helps with keeping swelling down and pain relief. After that, typically, heat brings more blood flow to the area and encourages healing. And sometimes it comes right down to which feels better. I have patients that say ice doesn't do a thing, but a heating pad feels great. In that case, use the heating pad.
Perfect. Okay, looks like that does conclude our
right.
question and answer portion of our seminar. Again, I want to thank Dr. Capra here for joining
Thank
us
you.
today. I want to thank everybody who took time to join us to learn more about your hip and joint replacement options. If you do have any follow-up questions, please call or email the contact info you see here on the main screen.